The title of presentation, meanwhile, is going to be Integrating Novel Agents and Allogenic Transplant in Myelofibrosis.
Hello, good morning, everybody. I hope you can hear me. It is a real pleasure for me to be with you this morning, talking about the introduction of novel agents in the management of patients with myelofibrosis regarding particularly to transplant. See, these are my disclosures. And this is the outline of the presentation. First, a few words on the survival outcomes in myelofibrosis nowadays. Then I'm gonna summarize, very briefly summarize the current treatment and the new therapeutic agents for this disease. Then I will go through the transplant decision-making and timing of transplant currently, and some recommendations on how to optimize transplant outcomes, and then go to the conclusions. First, let me show you the results of the outcomes of myelofibrosis in the JAK inhibitor era. So these are patients diagnosed after 2010 in Spain. This is the National Myelofibrosis Registry that comprised more than 2,000 patients, but diagnosed after 2010, there were more than 1,500. And here you can see the median age at diagnosis is 69, and the median overall survival is 6.6 years. And on the right-hand side, you can see that leukemia continues to be the main cause of death, but most of the patients die due to other causes. And actually, I usually say that any drug or any therapeutic strategy that is able to reduce the risk of these complications, even if it does not affect the clonal evolution of the disease, it may improve survival in myelofibrosis. And these are the relative survival of myelofibrosis compared with a matched population, a general population, matched for age, sex, and calendar and year. This is the survival of the matched population, and this is the survival of the patients in myelofibrosis diagnosed after 2010. And as you can see here, the relative survival at 10 years after diagnosis is less than 50%. So there is a huge decrease in the expected survival of myelofibrosis with the current therapeutic strategies. And as you can see here, if you stratify patients based on the IPSS, there is a decrease in the expected survival regardless of the risk group. Although, of course, this loss of life expectancy is much worse when the patients are diagnosed within the high risk categories. For instance, the expected survival at 10 years in patients diagnosed within the high risk IPSS is less than 15%. So here we have the only curative treatment nowadays, which is transplant, allogeneic stem cell transplant. These are the results of the EBMT in a large series of nearly 3,000 patients. And broadly speaking, around 60% are long-term survivors after transplant. It may depend a little bit on the donor type. But there is very few data on the number of patients that actually are taken to transplant in the real world life. And these are data again from the Spanish registry, patients diagnosed in 64 centers with a median follow-up of a little bit more than 5 years. Only 10% of the patients actually were submitted to transplant. If we go down to those diagnosed at an age of 70 or less, 18% of the patients receive during the follow-up period an allogeneic stem cell transplantation. So only 1 out of 5 patients diagnosed with myelofibrosis go through this potentially curative process. But the number of transplants in myelofibrosis is increasing, as shown in this slide by the EBMT, continuous increase, particularly in the elderly populations, in patients older than 65 years of age. So what is the alternative for transplant that is actually received by most of the patients? This is a non-transplant approach. Basically, a number of strategies to treat anemia, erythropoietin-stimulated agents, momelotinib, which is a novel important agent in this setting, danazol or prednisone, and then JAK inhibitors mainly to control the myeloproliferative manifestations of the disease. And then do not forget to prevent thrombosis in this disease. And here, of course, it is very important to have more information on clinical trials with novel agents. And if we are talking about novel agents, we are certainly talking about momelotinib and pacritinib because these drugs are JAK inhibitors that have very recently been approved in Europe and in the US. And they are very interesting drugs to be used in patients with cytopenias in myelofibrosis. They are less myelosuppressive, and also they have the benefit of potentially improving anemia. So these are the new incorporations of in the real world setting. Then there is a number of drugs that are actually a TGF beta inhibitors, are actually drugs interesting to improve anemia, and there are some favorable results with these drugs, but they are not yet approved at least in Europe. And then there are the combinations of JAK inhibitors with different drugs targeting new pathways, imetelstat, pelabresib, nab-pematlin, and selinexor. And the results so far are very interesting regarding symptom control and also histologic and molecular responses. But I should stress that regarding the molecular responses, the results are still very preliminary. And of course, everybody is very enthusiastic on the use of more driver mutation-specific agents, such as antibodies targeting the calreticulin, the mutated calreticulin on the surface of the cells, or the more specific JAK inhibitors that actually target the mutated clone and not the unmutated clone. But these drugs are in trials in very early clinical development in phase 1 trials. So there is still some time for this drug to go into the clinic. So for the time being, I say that the general algorithm that we have and the spec recommendations that have been published so far remain the same, which is first to consider patients as candidates for transplant if they have an expected survival of less than 5 years with conventional treatment. And this is the first step that we have with your patients in the first visit and then throughout the follow-up. Then it is important also to estimate the transplant risk, particularly to decide on the timing of transplants and times. And then it's important also to consider the patient perception of this balance of potential benefits and risk. So I'm just going to go very briefly through disease risk stratification, how we identify patients with a survival of less than 5 years. There are a number of prognostic scoring systems that have been validated in different series. On the left-hand side, you can see what we call the Clínico hematological prognostic scoring systems. On the right-hand side, the ones that include also molecular profiling. And then there are some models that have been developed with artificial intelligence, or they have a more personalized approach to estimate the risk. I think they all perform really well to estimate survival, but there are some things that you should know is that when you apply these models into the younger age population and with the current treatments, usually only the high risk categories identify those patients that are clearly within the high risk, what we call less than 5-year median overall survival. In the intermediate risk category, there is usually a wide spectrum of patients with a very heterogeneous disease course. So to estimate the transplant risk, we have the following scoring system. The one that we have been applying during the last years is what we call the MTSS, that was developed in Europe, in Germany and French center. And as you can see here, it takes into account some patient characteristics, disease characteristics, and the type of the donor. And it stratifies patients into 4 risk categories. Those within the high and very high risk category, they have an estimated survival of around 30% at 5 years. So you have to think a little bit more about taking these patients to transplant. This model is very useful, but it is important to remind that it lacks information on comorbidities, which is very important in the transplant setting. And also it did not include patients transplanted from Aplo donor or using post-transplant cyclophosphamide, which actually are modalities that are increasingly being used in worldwide. So for that reason, we recently developed a different prognostic model within the EBMT, an artificial intelligence model. And there is an online calculator that you can see, and basically includes several clinical hematological parameters that are considered not with cutoffs, but continuously: age, comorbidity, and performance status, and so on. This model was developed in more than 5,000 patients with myelofibrosis and also included a pre-identical transplant, patients receiving post-transplant cyclophosphamide. And what you are going to see when you fill in all this information is you will see a risk bar, and your patient would be here with a black arrow showing the risk of your patient, the high risk, intermediate, and so on. And broadly speaking, those patients that fall into the low risk category, they have around 15% all-cause mortality at 1 year. Those within the intermediate category, 25%, and those within the high risk category, 40% 1 year overall mortality. So this is important to take into consideration. So finally, we have to sit with the patient once or many times to have the informed transplant decision making. And in this could be kind of simple thing in this case with a high risk disease and low risk of mortality after transplant. But then in reality, you see many times that the information is not so clear and the patient doubts. And this is what I'm going to deal in the next slides, is the timing of transplant, because this is, for instance, the experience of Toronto, which I think is very relevant. This is a very important transplant center in Canada, and among the patients that they have a clear indication of transplant, around 50% actually refused to go to transplant upfront, and they decided to go through medical therapy first. And then afterwards, they actually analyze the results of those potentially candidates for transplant, younger patients with TIPS intermediate 2 or high. And as you can see here, 35% of these patients were taken to transplant directly, which is quite a high proportion of patients. And then the rest receive JAK inhibitors, and some of them actually eventually were transplanted. And this on the right-hand side, you can see the survival curve that actually crossed only after 5 years, and there was not a significant difference in overall survival. So with this strategy, you may lose, obviously, some patients through the path because they were candidates for transplant, but they lost the window of opportunity. But also, if you are having close monitoring of these patients, the results are not definitely so different, at least in this experience. But it is very important to monitor carefully these patients that are actually candidates for transplantation due to their high risk of disease. And we have some tools to anticipate the treatment failure. For instance, this is the RRC model that was developed in Europe in patients receiving ruxolitinib, in which, depending on the ruxo dose, the spleens reduction, and the need or not of red blood cell transfusions, you can actually identify risk groups, and the higher risk category has an expected survival, once again, of less than 3 years. So you can anticipate, after a few months of treatment with ruxo, those patients that again have a red flag that they may progress soon. Even if you've been receiving the JAK inhibitors and this treatment fails, At this time, consideration of transplant is again very important. These are data from the Princess Margaret from Toronto. Patients younger than 70 years of age, transplant eligible, and some of these patients with, of course, this is not a randomized trial, some of them received medical therapy and their median overall survival was only 2 years, whereas those patients that were taken to transplant had a better outcome. So again, here, very important message to take these patients to transplant. But the reality is that we have other drugs, particularly momelotinib, and some patients failing Ruxo, they did so because of cytopenias and so on. And now there is the trend to change Ruxo, for instance, for momelotinib, and that also is able to induce anemia responses. But what is the survival of these patients? We can see that in the simplified to clinical trial. In this trial, patients failing to Ruxo mainly due to cytopenias were randomized to receive momelotinib or best available therapy, and there was a crossover. But as you can see, in the whole series, the median overall survival was around 3 years. So in all these patients failing to Ruxo, they are all high-risk patients. And for this, transplant should be considered. You will have more information in this setting. For instance, this is a Ruxo myelofibrosis real-world study mainly from Italy. Patients failing to Ruxo, they were managed in the real-world setting by conventional treatment, including Ruxo rechallenge. These patients actually had a median survival of only 1.5 years, but there was another group of patients receiving novel therapy, including fedratinib, momelotinib, and so on, and the median overall survival was nearly 3 years, like in the simplified 2 clinical trial. And there were some patients that received transplant. And as you can see here with the survival curve, this was the patients that did better. Of course, the clinical condition of these 3 patient cohorts were different. But you have to think about when you change JAK inhibitor and in a transplant eligible patient that the risk of acute leukemia continues throughout the treatment. And if the patient finally progressed to acute leukemia, the results of transplant are not so good, are around 20% at the median term. So let's go to transplant optimization, which I think is a phase stage where new drugs plays an important role because, for instance, the performance status of the patient is critical concerning the results of transplant. These are Karnofsky performance status before transplant in the EBMT cohort, showing that those that have a better performance status do better after transplant. And then the spleen size. Those patients having a large spleen, they have an increased risk of graft failure, poor graft function, but also increased non-relapse mortality. And this can be seen, for instance, in these curves, these plots, cubic splice plots showing a linear effect of the spleen size. Here you have the spleen size before transplant and the outcomes. And there is a linear effect on the longer the spleen size, the higher the relapse risk and the non-relapse mortality. So this is something that we have to take into account. And there is this retrospective study showing that those patients that have the largest spleen before transplant, they have the poorest survival because they have the higher risk of non-relapse mortality. So here, novel drugs are very useful drugs. The patients, this is the EBMT, European Leukemia Net recommendations that were published a couple of years ago. And the idea was to give some guidance on what to do regarding a spleen. So, and clinical condition, those patients that have a good clinical condition and they have a spleen of less than 5 centimeters below costal margin, they can go to transplant directly. But those that have a spleen size palpable longer than 15 centimeters below costal margin, we do not recommend these patients to be taken to transplant entirely, but it is better to change treatment if the patient was receiving Ruxo, another JAK inhibitor, or another strategy, radiation, and so on, to improve their condition before transplant. And now there is some data on the use of fedratinib, very small data so far, showing responses. This is the median spleen reduction of 12 centimeters in patients failing to ruxolitinib, which is very interesting, or also with pacritinib. This is the Holborn study with not so important results regarding spleen size reduction, but many of these patients, they did not have a large spleen. But these are useful drugs in this setting to prepare the patient for transplant. And of course, we would like to have other drugs, like for instance, pelabresib, that showed in a clinical randomized trial much more effectiveness in combination with Ruxo to decrease the spleen size. That could be very useful for our patients if this drug eventually could be approved. And then there is in another setting that the new drugs are interesting, and this is the post-transplant prevention of graft-versus-host disease. And there are a few centers, but I think this is increasing in real world life, that are using JAK inhibitors after transplant till day plus 30 or plus 90 in order to decrease the risk of graft-versus-host disease, and the results so far are very promising. So these are my conclusion. Despite the introduction of novel therapeutic agents for myelofibrosis, allotransplant remains the only curative therapy. Its indication is increasing, particularly in the elderly population. The optimal timing of allotransplant remains challenging and should be individualized, taking patient preferences into account. This is very important, but even so, another important message is the early referral for transplant consultation in potential candidates to have a close follow-up monitoring of these patients. And this is a chronic disease, so there is typically no urgency to proceed immediately to transplant, but we have to take into account that optimizing the timing and preparation of transplant is essential to improve the outcomes. And here, new agents may improve the patient's clinical condition and the spleen response, and JAK inhibitors can be useful to prevent graft-versus-host disease and the investigation in this setting. I think the mutation-specific agents may represent future strategies to prevent or treat disease relapse, since they are very specific of the mutated clones, and they are not going to affect the graft versus disease control. So they are potentially very interesting drugs to prepare the patient for transplant, or to use it after to prevent relapse, or to treat an early relapse. With this, I will be happy to have any questions you may have. Thank you very much for listening to me.
mob for the old one for Hodgkin's disease. This is one element. The other element is the Canadian experience you presented in your slides, where the transplant will give you the same outcome after 5 or 6 years as the best available therapy. Actually, this is more or less a screwed type of data, because if you look at the area under the curve of the survival, the overall survival curve of that study, the area under the curve where the transplant is actually much lower than best available supportive or targeted therapy. And also, if you consider the GVHD with a transplant and try to measure GVHD-free, disease-free, overall survival, you'll see that the transplant doesn't do anything for the first 7 or 10 years compared to the best available therapy. What do you think?
Thank you. I mean, you have raised many of the caveats of our standard of care in myelofibrosis, and I understand completely your message. But I mean, myelofibrosis is a different disease from myeloma or from leukemia. I mean, because it has, from one hand, is chemo resistant. I mean, you cannot. Myelofibrosis was treated. There were some trials with using autologous transplantation, and there was no benefit at all. And we know for many years that it's a disease that is chemo resistant. So chemotherapy has no role. So we have JAK inhibitors and so on, but chemotherapy is not the solution. On the other hand, it's not like myeloma, in which you have autotransplant, that is a very safe procedure in general. Here, the alternative is allogeneic stem cell transplantation, which of course has an inherent risk of mortality due to the procedure. So it is a difficult decision, because actually it's not acute leukemia where you have a very short median survival if you don't succeed with treatment. Median survival is only a few months. Here you have a disease in which you have 6 years median overall survival, and some patients can be alive more than 15 years. So I think here what you need to know and in what we base our decisions is in the prognostic scoring systems. So we need really to identify those patients that have a very high risk, because these patients can actually do poorly with treatment of progress to acute leukemia, and in that situation everything is going to go wrong probably, or you are going against the statistics. So I think this is a disease in which we need to know the dynamics and the risk of the disease. So our main advances have gone through molecular profiling and these sort of things. And actually, if you see to the American and European recommendations, they say consider candidates that have less than 5 years median overall survival. But the truth is that this is probably too broad, and I understand here, because this includes a very high proportion of the patients, maybe 40% or at least 35% just at the beginning of diagnosis. And the truth is that many of these patients actually do not go to transplant because they want to continue being well and control the disease with JAK inhibitors. And this is a reality. But there are these guidelines. I mean, guidelines say that you should take these patients to transplant, but then you have the conversation with the patient does not want, and of course, usually there is not the urgency to do that. So through my talk, I actually wanted to emphasize where to put the red flag again, and to have this serious conversation again with your patient and say, okay, I have to transplant you because otherwise you're going to die to disease. What I'm just gonna tell you what I usually do with my patient. When I see one patient into my clinic, because I not only a transplanted, I manage all myelofibrosis patients in my institution, I always think, is this patient going to be transplanted? Maybe not now, but throughout the disease course. Is this a transplant eligible patient? And this is one group. And then if it is not, I think differently. If this is not a transplant candidate any time through. And with the transplant eligible patient, I say, okay, I don't want this patient dying from complications of the disease. I don't want these patients to progress into acute leukemia and so on. So I take this decision making through the evolution of the disease, and this is actually a kind of what I've been showing you through my presentation. I don't want to be. I mean, you cannot be very strict saying something like this should go, because patients also have their own lives and they have their own ideas on when to go through a risky procedure such as transplant. But what I consider a failure is not to be able to take a patient to transplant and this patient dying from disease deterioration, and this is something that happens when patients are managed in small centers and they don't think or they consider the transplant till too late. This is actually the only way transplantation to have long-term survivals within the high-risk category. I mean, you say that the area under the curve, they may be lower because of the increased mortality of transplant, but actually, I mean, the only way you can have a patient alive after 7 years of follow-up is with transplant. I mean, with medical therapy, you will see a continuous deterioration of their clinical status. So this is how I see the situation.
Thank you. Thank you so much, Dr. Hernández Boluda. This is very informative, and definitely there is no substitute for clinical judgments. We use tools all the time, but we have to put them together to make sense. Any other pressing question? Because I think for sake of time, we may need to move to the next. Okay, Dr. Zahrani.
If you have a patient going to transplant and spleen more than 15 centimeter, as you recommended, you will do some sort of therapy. From your experience, you will prefer to do radiation or splenectomy or JAK inhibitor. So from your large experience, what you would recommend?
What we usually do, of course, JAK inhibitor is the first thing. Patients may be receiving Ruxo, but usually at lower doses due to cytopenia. So, for instance, 10 milligrams twice daily. So you have two choices. Either increase the dose regardless of cytopenias and transfuse the patient if needed, because it's just going to be a period of a couple of months before you take this patient to transplant. This is one possibility. I usually change to fedratinib, full dose with control. If there is again cytopenias, I don't bother about that. Most of these patients, I use spleen irradiation the week before transplant. So we usually give 10 gray of radiotherapy in 5 doses from 5 days. And then the day after this, we start the conditioning regimen. We do not perform splenectomy. It's really exceptional. And I think the number of centers that do that is decreasing significantly. So we go through spleen irradiation, although it's not magic. The data and our experience is that you have usually a median spleen reduction of around 6 centimeters or so before stem cell infusion, no more than that. But even though it's a good complement, I think, to the conditioning regimen, and it's very well tolerated.
Okay, go ahead, Sam. Thank you.
Okay, thank you.